Thank you for the invitation to take part in this important debate, and I wouldn't prejudge that yet. So, I am here to convince you that alkylating agents should remain part of frontline therapy in elderly patients. These are my disclosures. So the reason we are here today to have a debate like this is because the remarkably improved survival for elderly patients in the area of bortezomib and lenalidomide. And here on the right-hand side, on the left, you will see the results. This is history now for myeloma patients, and this is the 10-year anniversary of the publication of the results of the VISTA study, showing a overall survival, median overall survival for these patients of 6 years, and similar results from the first study based on Lendex. But the reason I show these studies is because the VMP and RD can form the basis and the backbone, obviously, of further improvements. And much has been done in the last 10 years. How have we tried to improve on VMP? Our Spanish colleagues have done much work here. We can substitute the alkylator for C. We can substitute it for thalidomide. We can omit the alkylator. We can add thalidomide, add the antibody. And of course, improvements on RD have been manifold, particularly in the relapse setting. So it is par excellence the backbone on which we can build multi-drug regimens, including ixazomib, proteasome inhibitors, and antibodies. And of course, we can combine V and R. But instead of asking whether we should keep alkylators, why don't we ask, why should we discard melphalan? Should we do that because novel agents are more effective? Should we do that because novel agent regimens have better toxicity profile? To approach this question, we obviously will look at data from available clinical trials, but we should also ask at the same time, what should be the best practice taking into account affordability and access? So I don't have time to show very much data, but I will start by talking about a couple of nice studies done by our Spanish colleagues about how to improve on VMP. And this was one of the earlier ones, in which the M was substituted with thalidomide. And the important thing to notice about this trial is the limited duration treatment followed by maintenance. 6 cycles of induction followed by reduced intensity maintenance. This is the answer. Both regimens produce an impressive PFS of 32 months with an median OS of over 5 years. The VMP arm does slightly better than the VTP arm. That may be telling us something about the role of the alkylator. But look here at what happens to patients who achieve CR. Their median PFS of 55 months is really very impressive for a group of patients who not that many years ago had a median survival of 2 years. And the overall survival you see of 80 months is impressive and tells us what we can achieve today for these patients. This is with VMP. And innovating VMP further, if you combine it with Lendex, and again, this is a nice study from our Spanish colleagues, instead of putting them together, but treating patients either sequentially or in an alternating regimens, the results are even better. And note again, this is limited duration of 74 weeks. And the implication of how we schedule treatment for these elderly patients will become clear as we look at a few more studies. This was a phase 2 study in 240 patients. And here in a nutshell are the top-line results. You see similar PFS and OS for both arms, but an impressive PFS of nearly 3 years and an impressive OS with 70% at 3 years. Importantly, about half of the patients are older than 75, and we've heard much already in the session about frailty and the elderly, and I'll touch on that again a bit later, and 20% of patients were high risk. Here you have follow-up data. Overall, a median survival of over 5 years. This is impressive data building on a VMP backbone retaining the alkylator. But the reason these results are so good, of course, is because of the depth of response that you're able to achieve with a regimen like this, with an MRD negative rate of 20% in the whole population. And for these MRD negative patients, their PFS at 5 years is 57%, and the OS is an impressive 76% at 5 years. So one more study based on VMP. We can add a fourth agent to make a quadruplet regimen to achieve even deeper responses. This is the Alcyone study. You'll have seen the results. And here you see the schedule is 9 cycles of VMP versus 9 cycles of VMP with DARA, with the continuation of DARA as single agent after the end of VMP. And once again here, the top-line results with a separation of the PFS curves. In the VMP arm, the median PFS is 18 months, and the DARA VMP arm, the median is not reached. The hazard ratio is 0.5, and of course, once again, these impressive results are achieved because of the depth of response seen. In the quadruplet arm, with the addition of daratumumab to VMP, the greater than VGPR rate is 71% versus 50%, which is still not bad in the VMP control. The MRD negative rate is 22% in the DARA VMP arm, and here you see this translates into an impressive PFS advantage, which is similar, interestingly enough, at least so far, between VMP and DARA VMP patients, suggesting that if you achieve MRD negativity, then perhaps the treatment arm is not so important. We need longer follow-up for that. Whereas for those patients who remain MRD positive, there is a clear separation of the VMP versus and the DARA VMP arms. Possibly the benefit of continuing on single-agent attenuated treatment. So we know what we want from a first-line regimen in older patients. I've talked about depth of response, long disease-free interval, and the important thing about the new VMP regimens today is the low toxicity. In the alternating versus sequential scheduling of VMP versus RD, the grade 3 neuropathy was less than 5%. But we also want a patient-friendly, simple schedule, and we need an affordable schedule as well, and long-term safety. And that brings me to talk about fixed duration or extended therapy treatment. But I haven't said a single thing about RD, so now it's time perhaps to mention RD. And this is one of the studies in which an alkylator has been added to lenalidomide to see if benefit is improved for patients. This is a nice study presented by Sarah Bringer and Ash last year. And here you see initial treatment with RD or MPR or CPR, followed by our maintenance or RP maintenance. And these were 9 28-day cycles. You see, for the whole group of patients, it doesn't seem to make that much difference whether you got one of the triplets or the doublet. But if you look on the right-hand side, the patients divided up into the fit, intermediate, or frail patients, a different story emerges. You will see that for fit patients, there does seem to be an advantage of the addition of an alkylator into a triplet regimen, with a median survival of 83 months versus 50 months for the doublet. But this doesn't seem to be the case for the intermediate or frail patients. Perhaps the answer is here. If you look at the toxicity for the fit, intermediate, and frail patients, you will see that the discontinuation rates from AEs is much higher for the frail patients compared to intermediate and fit, as well as the non-hematological AEs. So perhaps the answer isn't the same across the board, but of course it isn't. You've been hearing about frailty assessment and the allocation and stratification of elderly patients according to frailty risk. So perhaps adding an alkylator to Lendex improves the outcome for fit patients, but not for frail patients because of increased toxicity. But anyway, maybe IMiDs are not the best partners for melphalan. So you thought I wasn't going to mention cyclophosphamide. Well, cyclophosphamide is beloved in England, of course, and it's been the backbone of national studies for years. It is a good partner for many of the novel agents, and the MRC myeloma studies have partnered it with IMiDs. So perhaps it's a better partner for IMiDs than melphalan. And this is the myeloma 11 study in transplant non-eligible patients, in which patients received either CTD or CRD with attenuated dexamethasone, that's what that little A stands for. And patients who failed to achieve at least VGPR were randomized to receive a second-line CVD or no CVD. And I'm not going to show you the results because I haven't time, but what I will tell you and want to show you here is that on the top, the thalidomide arm, and the bottom, the lenalidomide arm, that actually the tolerability of this regimen in the elderly above the age of 80 compared to younger patients is not that different. And that's important if we're designing upfront trials for this elderly group. So the discontinuation due to toxicity is 13% in those above the age of 80 versus 9% in those under the age of 70. But let's come back to Lendex now and think about what the real potential for Lendex-based combinations in this group of patients might be. We've already seen, and we know from the relapse setting, that Lendex-based combinations, triplet combinations, maybe even quadruplet, are very effective. High response rates, deep responses. But what about long-term complications? Now, I will remind you that in the Pollux trial, there was a 39% rate of grade 3-4 infections with the DARA-RD arm versus 26% with RD in the RD control arm in the Pollux trial. And that was young and old patients, many at first relapse. What about our elderly patients who are unseen patients at first diagnosis, not to mention cytopenias, long-term bone marrow failure? But another very important point, of course, and finances have been mentioned before in the previous speaker, is the financial toxicity. Lendex is not available in many countries, including England. We do not use Lendex upfront for our newly diagnosed elderly patients. So it becomes critical how affordable Lendex combinations when we're thinking about using them for extended therapy, and how safe will extended therapy be for this elderly group of patients. Let's come back to melphalan. I would argue that melphalan is an old friend. It is the first effective drug in myeloma. It's cheap, affordable. It's an effective partner with novel agents, including antibody. And let's not forget that it's the mainstay of high-dose therapy and stem cell transplantation in younger patients. So this is an effective drug against myeloma. So to summarize, I would argue that melphalan and cyclophosphamide retains valuable place in frontline regimens today. They are good partners with bortezomib. I haven't had time to show you the data with bortezomib and cyclophosphamide. There's less data out there, but they are well-tolerated combinations. We have to remember, of course, about frailty, stratification, and perhaps frail patients may be best treated with doublets. But I think the devil's in the detail, really. If we can design good, effective, well-tolerated multi-drug regimens, there's no reason why we can't get benefit from melphalan-containing regimens, upfront and then de-escalating once you get a good response. And I would argue that Lendex combinations have to show affordability as well as long-term safety before we can say goodbye to alkylators. And I shamelessly borrow this slide from Maravi, who gave this talk at a debate maybe 3 years ago, to argue that, well, melphalan is a bit like jeans. They're still fashionable and there's still a place for them. They just have to change with the times and make new combinations. Thank you.
Thank you very much. So Kwee did very well. She basically said melphalan is an old friend, which is a little bit strange, to be honest. But what is true is that it's definitely old. And this is 1969. In fact, the story started before 1969, but still, it's 50 years ago. This is melphalan and prednisone. She also decided to put the discussion on elderly. But if you want to be provocative, you may want to say some words on high-dose melphalan as well. So the high-dose melphalan story is more than 20 years old. So this is 1996. This is the first New England Journal paper from Dr. Attal, showing that transplant did much better as compared to old, traditional alkylating agent-based regimens. So if you want to, just to say a few words on high-dose melphalan and transplant, I would agree to say that transplant remains a standard of care for the younger transplant-eligible patients. And Philippe will likely say the same at the end of the afternoon. But I would say for how long? And you can go back to this very well-known story, the study we published in the New England Journal last year. And as you know, this was VRD versus VRD in combination with transplant. And as we all know, there was a PFS benefit moving from 36 to 50, but there was no survival benefit. And we may have a survival benefit at the end of the day, but not sure. And in fact, as far as I know, statisticians have said that it's quite unlikely that we will see a survival benefit. If you want to push a little bit, you have to go to MRD. So this is a well-known slide from Professor Ravel-Loiseau. So this is PFS, this is MRD negativity at 10⁻⁶. And if you look at the top curves, you have the transplant arm and you have the VRD arm, which means basically that if you can achieve MRD negativity at 10⁻⁶, at this stage there is no benefit in terms of PFS for the transplant. So I would agree to say that if you look at high-risk patients, there is a need for transplant. You may say there is a need for double transplant. But if you go back to the standard risk patients, and the standard risk patients, this is approximately 80% of myeloma patients, what is exactly the need for frontline transplant in standard risk patients? And this is the old VRD. In few years, we will have VRD in combination with a CD38. So my question is, what will be exactly the need for transplant at the time your induction will be the combination of an IMiD, a PI, and a CD38, the same for consolidation, and a maintenance which will be also quite effective. So these are just very limited results regarding transplant, but you know, even the transplant will be challenged in the next few years, so which means that high-dose melphalan will be also challenged. And if you look again at study results with transplant studies, in fact, the benefit is also due to a much more effective induction, consolidation, and also, of course, maintenance. And this is especially true if you look at lenalidomide maintenance. And if you look at this ongoing IFM study, the induction and consolidation is VTD in combination with daratumumab, and some patients will get daratumumab maintenance. So this is a transplant study. But having said that, the induction is quite strong, the consolidation will do well, and the maintenance will likely do well as well. So everything is moving forward very fast. So my point is just to say that transplant will be challenged for some patients. And then back to the question we had in the previous session, if you want to discuss the issue of transplant in elderly, in patients around the age of 70, I would say that you can do probably much better with new combination regimens. Back to the elderly. So do we still need frontline melphalan? And The first answer is the first study. So the first study was a comparison between lenalidomide and dexamethasone and melphalan, and thalidomide. So this is a unique study. So the goal was to show that 2 drugs would be able to do better than 3 drugs. Usually this is the opposite. Usually you try to show that 3 drugs are better than 2. So we were able to show that 2 drugs were better than 3. And basically this is what we got in terms of survival. So you may want to discuss Lendex continuously versus Lendex 18. This is another debate. But what is true here is that if you look at both arms, having lenalidomide and dexamethasone, both arms did significantly better as compared to melphalan, prednisone, and thalidomide for PFS and for survival. And basically, you move from median survival 4 years to median survival 5 years. Then you have to say that lenalidomide and dex is a standard of care, but it's the start of a new story, because you can build on lenalidomide and dexamethasone, and it has already been done. So this is the VRD regimen. If you prescribe VRD, you will get median PFS approximately more than 40 months, and you will get median survival 75 months. You could say this study was a study for some elderly and some young patients, but anyway, you will get nice study results in terms of PFS and in terms of survival. And because of time, I will not be able to discuss that, but the VRD can be managed in elderly, and colleagues in the US have developed a VRD light regimen, and this VRD light regimen has provided median PFS 35 months, which is quite long. And this is the beginning of a story, because this is what we will get in the next couple of years. What is shown here, and what you have on the left-hand side, is what we have done in the past few years. What is ongoing is what is shown on the right-hand side. So the first is the daratumumab in combination with VMP. So Professor Yong nicely showed that Dara VMP is a nice regimen. She did not really mention that the median PFS with VMP alone is only 18 months anyway. But basically, the study has shown that daratumumab is a good drug. The point is that this is likely the last alkylating agent-based regimen you will see. And most importantly, it will be extremely difficult to improve on it. What would you do? Would you add another drug? So it's impossible to move forward from DVMP anyway. On the other hand, if you have in orange all lenalidomide-based regimens, or you may say the VRD is a bortezomib-based regimen if you want. So VRD, and you will get Lendex in combination with ixazomib, in combination with elotuzumab, in combination with daratumumab. These regimens will be extremely effective. And finally, this was melphalan prednisone in combination with carfilzomib, and the study did not meet its primary endpoint. So you will not see any KMP on the market. So basically, the story will be in favor of alkylating agent-free regimens, because the story will be in favor of either VRD or the combination of lenalidomide dexamethasone with either ixazomib, elotuzumab, or daratumumab. The next part is very, very easy. It's safety. So it's important to protect patients for adverse events. And again, I will go back to old slides and old study results. It's very well known that you can get acute leukemia with alkylating agents. It has been shown. So this is a paper from 1979. And in this New England Journal paper, as you can see, the incidence of acute leukemia was 5%. More recently, and this is the SPM discussion in the lenalidomide containing studies, I would say, the 2 transplant studies with lenalidomide maintenance and MM15 study with MP in combination with lenalidomide. And as you know, there was an excess of second primary malignancies, including hematologic malignancies. If you look more specifically at the combination of melphalan prednisone and lenalidomide, this is what we got in terms of hematologic adverse events, hematologic SPM. So 9 patients in MP lenalidomide followed by lenalidomide maintenance, 6 patients in MP lenalidomide, and only 2 with melphalan prednisone. But anyway, you get leukemias, which is basically bad. In contrast, if you look at the first study with lenalidomide and dexamethasone, the signal is very, very low. In fact, there is no signal. Looking at Lendex given continuously, you will have 3 patients out of 532, which is the bottom line. This is only 2 patients with Lendex 18. This is less than 1%. This is 0.5%, something like that. And in contrast, if you look at melphalan prednisone in combination with thalidomide, we had 14 patients, which is 3%. So that's a difference, and that's based on approximately 1,500 patients. And if we go back to some things to the IFM studies, I would say. So in the IFM, we did, recently we did 2 studies. We did the IFM 2009 for the younger patients, and we did the first study for the elderly. So IFM 2009 is interesting. I mentioned efficacy results, but if you look at SPM, what is said in the New England Journal paper is that the incidence of SPM did not differ significantly between the 2 treatment groups. But on the other hand, we had 5 cases of AML, 1 in the VRD arm, and 4 in the transplantation group. You may say it's statistically not significant, but you may also say this is a kind of imbalance. And in the first study, as I said before, you move from less than 1% with lenalidomide and dexamethasone to 3% with the combination of melphalan prednisone and thalidomide. So my point is that there is a safety signal regarding acute leukemias with melphalan, and this signal will remain. This signal was observed in the old time. This signal has been observed in the most recent studies. And what was acceptable 50 years ago or 40 years ago might be no longer acceptable at the time the median survival of myeloma patients will be between 5 and 10 years. And maybe some patients might be cured. So my conclusions are very simple. In fact, if you look at doublet or triplet alkylating agent-free regimens, basically these regimens, they have greatly improved the outcome of myeloma patients. And this will be the case in the next 5 years. If you look at frontline low-dose melphalan, it is associated with a 3% incidence of MDS or AML. And it was the case at the time the median survival for myeloma was approximately 3 years. So should we expect more with a median survival of 5 to 10 years? I think possibly yes. And finally, and I think this is likely the most important point, these alkylating agent-free regimens provide a much better opportunity to improve the clinical outcome of myeloma patients. Because if you still stick on melphalan, you will be unable to improve a lot on these regimens. You will not be able to improve a lot on DARA VMP, for example, but you will be able to combine an IMiD, a PI, and a CD38. And some myeloma patients might be cured in the next few years. Thank you very much for your attention.